underlying resistant populations.
Okay, thank you. There's a question from Deme, which is about, I think here he's talking about the bovine Mycobacterium tuberculosis.
Right.
He's asking things. I think the question is not very clear, but it's about people feeding on raw milk and how to control the way of human. I don't know if there's direct answer to that or how applicable it is to the context of this session.
I think it's an interesting question, and thank you for it. You know, I think that let's think about the fact that cows have M. bovis.
Yeah.
But we've done some studies in Nigeria with colleagues there, and we have found human TB in animals, in cows, particularly between the herdsmen and their cows. So the question then is, you know, can you get TB from cow's milk or from eating raw meat or drinking raw blood? It's a real possibility. And I know there's some work that's been done in South Africa that in cows, they've actually found drug-resistant tuberculosis, not drug-resistant bovis in cattle. So it is an important question that one must consider. Obviously, M. bovis tends to play the major role, but in South Africa, that's our problem is really in the wild animals rather than in cattle.
Okay, thank you. Thank you for that. And then we've got Andrew Baguma again asking about resource-limited setting. So he says the treatment is basically done after a smear positive. And he's asking, how can we adapt this very important whole genome sequencing to get the way in which we manage our patients cheaply? I think cheaply is the key point here.
Yes. Now, I again, a nice question, because this is exactly what we have been saying to the companies that are making these instruments and providing the kits, that we can't have the costs. If this must be implemented, we need the costs to be reduced by, you know, a couple of hundred times. In other words, let's say the current cost is $100, American dollars. We want it to be down to $20 or $10. Because then I think uptake will be much, much better and it will really benefit people.
Yeah.
So we're definitely pushing for that. The question of going from smear positive to a genome sequence, I think you need to have at least, if patients are at high risk, then there should be a gene expert done to be able to identify patients that are at high risk. But that does mean that all primary drug resistance, in other words, patients who've never had TB before, who have rifampicin resistance, are missed. And that is a big opportunity that must be addressed, because those patients will be treated with the wrong regimen. They will acquire more and more resistance, and they will spread that resistance.
Thank you. Thank you, Prof. I think there's a participant asking that they want the lecture. I think we will share the lecture and the slides to everybody who registered for this talk at the end of this talk. So to continue, I think I will take this question from Jocelyn Van Buren, and she's asking for clarity in SMART, the SMART is a 3-week delay from culture result or submission of culture by patient.
So thank you. It's basically from when the patient submits the specimen to the laboratory that does the initial culture. So it's the time from when so maybe I just must take a few steps back. So in South Africa, in this particular area of South Africa, we primarily screen with Expert Ultra, all right? But we only collect one specimen. So that ultra test gets done, and if rifampicin resistance is noted, then the patient is called back to the clinic to give another specimen. So that there may be a delay there, all right? And then that patient is generally started on some form of therapy. Then from that point on, we count from the time to the 16 days or 21 days.
Okay, great. And she's also, there's another question as a follow-up. What are your thoughts on BPAN regimen, given this BDQ resistance finding? How worried should we be?
So that's another very good question. Wonderful questions today. I think we're very worried indeed, because we really need to make sure that we prevent resistance from emerging, which means we need to keep people in therapy. We also need to make the right decisions in terms of diagnosis, that we don't undertreat patients with bedaquiline so that there's not enough supporting drug. So we actually are thinking ahead of this in BPAL-M. What will we do for patients who have resistance to any of those drugs? Would we want, and this is a study that we're starting, it's going to be called CORRECT, with our colleagues in Antwerp, and it is really saying, can we do a sort of similar study like SMART on patients who are diagnosed with fluoroquinolone resistance, or by chance have linezolid, bedaquiline, or predominant resistance? And then what would we do? How would we treat them? And can we use next-gen sequencing to guide that? So yes, I think it's a very good question.
Thank you for that. Then there's one from Davis asking, as we move to NGS to clinical settings rather than academic, do you think nanopore sequencing would be best option than Illumina?
Another brilliant question. Yes, absolutely. I'm very much in favor, and I've again expressed this, and I'm on an advisory committee, that we need to have platforms that don't need to have a large number of specimens, that we have to wait to fill up that flow cell. We want to be able to do it cheaply and maybe only have 2 or 3 specimens in a flow cell. And so nanopore is an attractive option. So the study that I showed last with the D-plex, that study, we hope, initially will be on Illumina, and then we will move it over to nanopore.
Okay. So there's a question of collaboration, which I think 2 participants have asked, but we can take that offline. Professor Rob Wallen will provide his contact details. And then there's a question about INH, one from Henry Mapesi and Catherine. So Henry is asking what are the consequences or treatment outcomes of patients with INH resistant but IRF susceptible who receive normal treatments. And then Catherine is saying it's worrying to see such a high prevalence of INH monoresistance. Do you know what lineage these isolates belong to?
Right. Good questions again. So just the first one, there's been quite a few systematic reviews looking at this. And I think the general feeling is that if you have isoniazid monoresistant strain, you are at a higher risk of recurrence. Okay, another following episode. You're at a higher risk of acquiring rifampicin resistance, and you're at a higher risk of treatment failure. Right? It does not mean that necessarily all patients mitigate that risk to make sure that these patients don't relapse and then continue to spread it, don't acquire additional resistance, and become MDR, even more difficult to treat. So I think those are the major concerns. In terms of the second question was about what's driving the epidemic?
The lineage.
The lineage, sorry.
Yeah.
So in our instance, we have identified Beijing, an atypical Beijing, as being the predominant lineage, but they're not all in one cluster. There are multiple Beijing strains with different isoniazid conferring resistance mutations. So it's not as though we are seeing a lot of transmission. We are planning to do a new study and to try to understand where the isoniazid monoresistance is spread. There is some data from the United States back in the 1990s, and that certain mutations spread better than others. But I think the main clinical question is, what is the underlying reason these patients have isoniazid monoresistance? Have they been treated before? What was the outcome of their previous treatment? All that sort of data needs to be put together. What happens when you have HIV positivity on antiretrovirals, not on antiretrovirals? Does it influence? As I've mentioned, IPT. Is IPT being administered in a manner that is continuous, or is it sporadic, etc.? A lot of questions.
All right. Okay, yeah, so thank you for that. So I will go to a question here by, I think it's Sylvester Moyo, talking about the BDQ resistance, and wondering if there's any clinical trials that are already looking to other drug candidates that can be combined with BDQ to reduce the development of resistance.
An interesting question. I think that there's many drugs in the pipelines. Whether they protect bedaquiline needs to be determined. I think that, it's only been used for such a short period. We have very little knowledge, but it's a very important point. How could we be reversing, for example, bedaquiline resistance, which is driven by an efflux pump? Could we inhibit that efflux pump and then restore susceptibility? These are sort of some of the questions that are coming up at the moment. Yeah.
Okay, so I will take 2 more questions, or 3, because in the interest of time. So we've got Afara asking that his question is rather unrelated, but about the Expert Ultra. Does it have the possibility to diagnose resistance due to L491F mutation? He's asking that because he knows that in Eswatini, there's disproportionately high proportion of RR due to that mutation.
My understanding is no, it doesn't.
Okay, and then we have Emmanuel Napolo with undetected BDQ resistance within 2 months. Which method could have probably detected it earlier?
So the targeted deep sequencing method is probably the only one that can allow us to find it early. And we have done some studies with other drugs to show that phenotype actually is not as sensitive as a targeted deep sequencing approach. Phenotype looks at 1% proportion, whereas targeted deep sequencing could maybe look at 0.1%. with some level of accuracy. So that's, I think, where we're aiming to go. And then I think we don't have the clinical trials to say, if we had found that resistance earlier, could we have changed the regimen, improved the outcome? We don't have that data yet. And there's a discussion in the world about heteroresistance. Do you keep the drug that is going to still kill certain proportion of the population, but not the other population? And that's out there in discussions, but I don't think there's concrete answers.
Okay. Thank you very much, Professor Warren. I think there's a few more interest in collaboration, people who have samples and asking if they can collaborate to do the drug resistance assays, the genomic assays. So there's Asiko, Ongaya, and Peter Mbelele. I think Professor Warren will provide the presentation together with his contacts, and you might be able to get him through that.
Sure.
Maybe we have just 1 minute, and I will just take the last question from Amani Mila. She's asking, my question of research is of the data of whole genome sequence could be used to identify to some extent new targets for new drugs or vaccine development.
I think that they're right. I think the strategy is, we know the genome, we know some of the genes, we don't know all. The ideas at the moment are really saying, how can we modulate the expression of genes in Mycobacterium tuberculosis to understand whether or not we can target them. I don't see really, unless we do a lot of what we call luria Malbrooks, which are these spontaneous mutation accumulation to try to find whether certain compounds are causing the genome to change. I think that's quite an interesting question, and I've actually proposed that once to somebody looking at traditional medicines as to whether they can accelerate genomic change in mycobacteria. That you could do through next-gen sequencing, but not actually necessarily identifying targets through whole genome sequencing of the bacteria without exposing it to something. Yeah.
All right. Yeah. So I think we will have to stop there. We are really at the top of the hour, and very grateful to you, Professor Warren, on behalf of everyone who has attended this webinar. Thank you very much for taking the time to speak to us on this very important topic of TB genomics. Ladies and gentlemen, on behalf of the Africa CDC, Africa PGI, I take this opportunity to thank you for making time to attend this webinar. Be advised that this is a bi-weekly activity, and we will have another one in the next 2 weeks, and we'll send you the login details, the registering and login details. I think we wrap up here. Just wish you a very lovely rest of the day.
Recording stopped.
Thank you.
Thank you very much indeed for the invitation again, and thank you for chairing, Sarah.
Yeah, thanks. Thanks, Prof. It was 20-something participants.
Wow.
Yeah.
That is fantastic. Thank you very much. Maybe you could keep me on the mailing list so that I can also know what.
Exactly.
And I can also offer to get other colleagues from the center to also present some of their findings.
Of course. So there's quite some very nice questions that came up. Maybe you might just have a look at them to get an idea of the kind of, so we still have some of them in the chat box. But I think some people wanting to collaborate, some people having even some retrospective samples that they would like to do drug resistance. So I think that is interesting.
Sure, absolutely.
Yeah.
Good.
But thank you. That was really nice.
Thank you very much.
Always a nice topic. Yeah, the TB topic is always very interesting.
Good.
Yeah.
Well, thanks again for inviting me, and thank you to the audience.
Sure.
And for the good questions. Bye-bye all.